Question that came up, and basically they were like, well, you know, if the blood pressure is low, then how come we see that the cerebral arteries, what do they do in that situation? They tend to dilate, right? And then if the blood pressure is high, they tend to constrict. So well, that seems kind of backwards. Like, why in the world is that going to be occurring? And then the reason for that is this idea of cerebral perfusion pressure. We'll probably talk more about this in the neurology section, but this is really important when you're talking about patients who have like traumatic brain injuries. It could have issues where they have increased intracranial pressures. And so essentially what you're running into, there are two different variables that define what your cerebral perfusion pressure is. And basically, cerebral perfusion pressure, or CPP, equals your mean arterial pressure, which is basically the average pressure within the arteries, minus your intracranial pressure. Okay, so pressure coming from the head, trying to combat the pressure coming in from the arteries. Okay, so you do the MAP minus your ICP, and that gives you cerebral perfusion pressure. The reason why that's important is because you need to maintain that within a certain range. If you go too low, then you can end up running into ischemia where you're not perfusing the brain very well. If you end up going too high, and that's where you can run into issues of like stroke, or you can damage some of those vessels. And so typically, do you guys are you familiar with the term MAP, or mean arterial pressure? You guys know how to calculate it by any chance? Basically, an easy way to do it is it's going to be 1/3 your systolic blood pressure and then 2/3 your diastolic blood pressure, because basically you spend about 2/3 of your time in diastole, about 1/3 of the time in systole. So by figuring out what that is, and for some people it's usually, let's say, around 80 or so, and then like your intracranial pressure should be around 10, say between 5 to 10. So what happens is, as your MAP starts to climb, that cerebral perfusion pressure is also going to be climbing as well. So if that ends up getting too high, what the vessels can do at that point is try to increase intracranial pressure, so those cerebral vessels will constrict to try to prevent too much pressure from coming into the brain, right? So as your MAP starts to go up, your ICP is going to try to go up as well to make sure that difference there stays roughly the same. Okay? If you were to have hypotension occur and your MAP starts to drop, the vessels say, hey, we need to get more blood flow coming here, so it's going to drop the ICP, relax those vessels in the cerebral, or the cerebral vessels, and that's going to allow more blood flow to come through. So that's what we call autoregulation, and so you can run into issues where you kind of go outside of those ranges, and you can run into some issues where either you have ischemia or you're having damage done to those vessels. Does that make sense? So you can look up autoregulation and cerebral perfusion pressure. There's some good articles out there, like on eMedicine and things like that. They'll kind of give you some better ideas. The thing we run into, like from the trauma standpoint, is when patients have traumatic brain injuries, they end up having cerebral swelling that occurs, and that increases the intracranial pressure pretty significantly. So the ICP starts to climb, and so it means is that difference starts to close, and so you don't get enough perfusion. So sometimes we have to either try to pull that fluid off the brain to lower that pressure, or we have to end up doing keeping the blood pressure relatively high in order to make sure that perfusion pressure works out. Okay, so it's basically making sure the pressure differential is going to be appropriate there to have good brain blood flow. Sometimes you even have to take out parts of the skull in order to allow for the brain to have extra room to kind of fill out a little bit. So we've done that occasionally. Not preferable, but basically you can take out a bit of the skull and like transplant it to somewhere else under the scalp, so that the bone still stays useful, still stays somewhat get some blood flow, and then you can put it back when the patient has kind of run out of that issue. So it's using your head, right? Okay. Anyway, so you guys just have to give me a heads up if the projector comes back. So we were talking about bioavailability. We're on that slide. I don't have that slide number because I kind of combine my stuff together. But we were talking about some of the definitions in regards to bioavailability and bioequivalents. So bioavailability is that fractional extent to which a dose of the drug gets to its site of action, right, regardless of the route of administration. So we mentioned for IV administration, what's the bioavailability? Should be 100%, right? We're giving drugs directly into the vein, getting 100% of the drug to the system. So that makes sense. But as far as like oral administration, what could be the issue there? Or what could be our bioavailability? Could be very variable, right? So it could be 0. Some drugs cannot be absorbed through the GI tract. Things like insulin, you cannot give insulin via the GI tract because those proteins get broken down by enzymes, by the stomach acids. It's no good. Some things will have 100% bioavailability, and that's important when you're looking, like when you're comparing, say, like IV doses of a drug versus the PO doses or the oral doses of a drug. You can see some drugs will have the same dose, which is pretty easy to convert patients from one to the other. Sometimes you may have to do a 10-fold dose increase on the PO version to make sure they're getting enough through that first pass effect and through bioavailability, right? And so we mentioned bioequivalence is going to be one of those two products. So you have two different products that contain the same active ingredients, and they're identical in that strength, concentration, their dosage form, and that route of administration. So this is really important when it comes to making generic drugs. We mentioned, you guys remember how long the patent life is on a chemical when they go for a new drug application or an investigational new drug? So 20 years, yeah. So it's 20 years they get to go through all the trials on that drug, and once they bring it out to market, they can make their money on it, whatever time left they have on that 20 years. After that period, that's when the generic manufacturers can come in and say, hey, we want to make that drug too, but they have to show that they have the same strength, the same active ingredients, the same dosage form, the same route of administration in order for it to be bioequivalent, in order for it to be interchangeable. Because one of the things that we do from the pharmacy side is if you write for a brand name drug, if a generic is available, we can automatically switch that out. There's a certain list where you can't do that, but for the grand majority of drugs, we are trying to do best by the patient, and so that's usually a cheaper alternative. We can do that unless you write very specifically that this has to be dispensed as written, or if you ever see DAW on a prescription, that is what that is referring to. So hey, we only want brand name drug for this, and so you guys can make that that clarification when you're writing a prescription. Okay. I'm going to go to slide. So we mentioned that bioavailability gets altered by several features. So either the route of administration, the acid-base status of the drug, so whether it's a weak acid or a weak base. We're going to see how that's going to be affected by the Henderson-Hasselbalch equation again. Looking at the environment that it's in, some drugs may be better absorbed in kind of the acidic environment of the stomach. Some drugs may be better absorbed in the more basic environment of the small intestine. Okay. We'll talk about absorption, how that can be affected, whether it is bound or unbound. Sometimes you can find that drugs will be bound up within the GI tract and can prevent it from actually being absorbed. We mentioned that calcium interaction with fluoroquinolones, or that class of antibiotics like Levaquin or Cipro. If you have calcium come and bind that up from, say, from milk or something, that would prevent the drug from getting absorbed. Bioavailability kind of goes to the ground, right? One thing, I mentioned first pass effect. You guys know what first pass effect is, right? That liver tax that we have, right, where the liver is going to metabolize some portion of that drug before it gets into the systemic circulation. And then excretion and elimination can also be affecting the bioavailability of the drug as well. So we'll get into all those details. Okay, so next we're going to that route of administration slide. Okay, so again, we mentioned this can be very variable. It depends on several different features. Again, IV is always going to have the best bioavailability there. Intramuscular, subcutaneous, usually pretty good for the most part. There could be some situations where it may not be absorbing quite as well, but for the most part, anytime you're giving it via the parenteral route, meaning through injection, that's going to be pretty good. Okay, so we covered that slide previously. So again, we're going to look at the acid-base status and see how this can affect absorption of drugs within the GI tract. I talked about this a little bit already, but we'll kind of review it one more time. We mentioned normal pH of the blood, the arteries is going to be what? Yeah, 7.35 to 7.45, so about 7.4 would be considered neutral for us. You're going to see there that things like, the gastric acid should be somewhere between 1 to 2. For the most part, so again, a very acidic environment, which may or may not impede drug absorption. You can have, obviously, things like the small intestine are going to try to neutralize that out in a lot of cases by secreting a lot of bicarb, and so you can end up seeing a much more kind of basic to neutral kind of environment there. All right, next slide. So again, looking at several different drugs. Some are going to be weak acids, some are going to be weak bases. Again, when you're looking at things like, okay, why is this drug given in this type of dosage form? Why is it given in these like little beads that are coated with this kind of acid-resistant coating? They've kind of taken all this into account for you. So, if you were to ask a practicing PA or even a practicing pharmacist for a lot of cases, is acetaminophen a weak acid or a weak base? They're not going to know, right? Because it clinically doesn't really come up. But drug manufacturers have already taken that into account to determine how best to administer this drug to make sure that the patient does absorb it. So if a drug does not come in an oral dosage form, that's because someone's already figured out that it doesn't really work that route. Okay? If it only comes IV, they know that that's the only way that we can actually give that med to get it into the system. Okay. So we mentioned that water molecules are going to be polar by nature, right? Because they're going to have the hydrogen being pulled to one side of the oxygen molecule. Those are going to have a slightly more positive side of things. Oxygen is going to be slightly more negative. So they're going to be more attracted to charged drug molecules. So I mentioned that things that are going to be more charged are going to be more water soluble, which means conversely they're going to be less lipid soluble. That's going to be impeding drug absorption in a lot of cases. So again, uncharged or neutral molecules tend to be more lipid soluble. They cross these membranes much more easily. So the next slide just kind of shows you an example of sodium, how that is has a permanent positive charge when it gets dissolved into water, how it has those polar molecules kind of surrounding it. A very similar thing happens to any of these drugs that are considered to be kind of more water soluble or more hydrophilic, right? And also certain animals may be more polar than others, may lead to some dissolution of them, right? Hope everyone got to the same slide together. Okay. All right, so looking at an example of a weak acid, we can see how bioavailability can be altered by changing the solution of the kind of the medium that it's in. So we said that aspirin is a weak acid. In this more neutral form, it can exist in a neutral form. It's going to kind of reversibly dissociate into the anion, or this kind of negatively charged molecule, and then a proton, right? So you can see here when it's in the neutral state, or the more protonated state, you're going to find that it's going to be much more lipid soluble. When it's going to be dissociated and it has that free hydrogen ion, you're going to find that it's going to be much more charged. It's unprotonated in this case, and it's going to be much more water soluble. So for absorption through the GI tract, which way do you think is going to be absorbed better? Yeah, probably the more protonated state and the more uncharged state, because that's going to be much more lipophilic. We still have to get across those lipid bilayers and things like that. Some things you're going to find are going to be better absorbed through things like pinocytosis or things like that. So like you think iron, I mentioned B12, that intrinsic factor. Those can be absorbed regardless kind of their charge state on those. But a lot of these drugs are going to be relying on either like carrier transport, or in a lot of cases they're going to be relying on basic diffusion, right? So in this case, aspirin is going to be able to cross those lipid bilayers much more easily when it's in the uncharged state, when it's protonated in this case. Okay. I'm gonna go pyrimethamine is going to be an example of a weak base. Sometimes you can use it as a anti-infective. Basically, you're going to find the neutral molecule can form a cation, which again is going to be a positively charged molecule, by combining with a proton. It's in the neutral state, or the unprotonated state, is going to be much more lipid soluble. When it's charged, or in the protonated state, it's going to be much more water soluble. Okay, so again, weak bases are going to be the exact opposite here, where if it's going to have an, if it's going to be in a more acidic medium where there's more hydrogen ions floating around, you're much more likely to get it into that kind of that neutral state. I'm sorry, when it's in a more acidic medium, you have more hydrogen ions around. It's going to be much more in that charged state, and that's where you can see this much more hydrophilic. It's going to be in a much more basic medium. When it does not have that charge on it, it's going to be much more lipid soluble at that point. All right, next slide. So we mentioned that Henderson-Hasselbalch equation. We kind of talked about this briefly before, but protonation just means it's combining with a proton. So again, hydrogen being the one here. Weak acids are going to be protonated. The protonated form is going to be neutral, right? So again, always think that like dissolves like. So if you have a weak acid, it's going to be much better dissolved in a more acidic medium. Vice versa, if you have a weak base, it can be much more dissolved better into a basic medium. And for weak bases, the unprotonated form is going to be neutral there. Okay, so uncharged, more neutral, means you're going to have much more lipid solubility. And you have a much easier time going to be absorbed through the GI tract. So going to the next slide. So you can see the ionization curve of something like acetic acid. So notice it has a pKa of 4.8. And what do you kind of notice about when the acetic acid is at that pH of the solution of 4.8? What do you kind of notice there? Yeah, so when the pH of the solution meets the pKa of the substance, whatever the drug is or whatever it happens to be, you're going to find that it's going to be 50-50 protonated versus unprotonated. And so again, by shifting that pH of the solution down one direction or the other, you can get a better ratio of protonated or unprotonated there, and try to change how lipid soluble the molecule might actually be. So just know when pKa equals pH, you're going to have a 50-50 distribution of protonated and unprotonated molecules. Okay. So for instance, we are looking at for basic and acidic drugs, you can look at that log of the protonated to unprotonated ratio. Okay, it's going to equal the pKa minus the pH. So if you know the pKa of the drug, and that's pretty widely available, on the internet and things like that, you can find lots of resources that will tell you that, minus the pH of the solution that it's in, you can figure out what the log of that ratio is between protonated and unprotonated. So in this case, mentioned the uncharged form is going to be much more lipid soluble. That means that for the uncharged form for acids is going to be protonated, and for the uncharged form for bases is going to be unprotonated. Okay, and that means that you're going to have more weak acids end up being lipid soluble in acidic pHs. More weak bases are going to be more lipid soluble at alkaline pHs. So again, something like aspirin, do you think it'd be better absorbed in the, say, at the stomach versus the small intestine? What do you think? Probably in the stomach, because as it's a weak acid, it's going to have a much better time being in a more protonated state, a more uncharged state when it's in those acidic mediums, right? Versus when it gets down into, let's say, the small intestine. The next slide. So we can also look at drug elimination, how this is also going to have an effect. So we mentioned kind of already how we can change the pH of things like the urine in order to either enhance drug elimination or to hinder it in some cases. So looking at excretion, you're going to see that typically weak bases are going to be usually excreted faster in acidic urine. And why do you think that is? So the weak bases will get filtered out of the glomerulus, they'll be going through the nephron, and then if they're in a more acidic medium, that means they're going to be charged or uncharged. Yeah, they're going to be much more in a charged state, right? Because more of those protons are around to combine with the base. That means it's going to be more charged. It's going to have a hard time being reabsorbed through those membranes, and thus it can be excreted more quickly, right? On the flip side of that, weak acids are usually going to be excreted faster and more alkalotic urine. So we do that a lot for aspirin overdoses. If a patient had overdosed on aspirin, we can actually alkalize their urine to get their urine pH up to, say, somewhere around 8. You know, normally kids would be between like 5 and 7 or so. We get it up to 8, and that is going to make it so that we have a lot more of the charged molecule, the unprotonated weak acid, and that helps to increase the elimination. So you can watch those levels. You know, person overdoses, they're going to climb, and they'll give them the sodium bicarb in their IV fluids to alkalize the urine, and then you'll start to see it drop pretty precipitously. So again, that's something we can do to reverse one of those types of overdoses. Have you ever heard of someone using something like baking soda along with their amphetamines? I don't know if anyone's ever heard of that, but basically, like, someone was like abusing methamphetamines for illicit purposes. Sometimes they would try to alkalize their urine as well, because we know that amphetamines are actually weak bases, and that by alkalizing the urine, you'd actually end up leading it to be more in the uncharged state and increase reabsorption of it. So that way you get to have the drug around for a little bit longer and have a little bit of longer high. So, not that I'm saying go do meth, but people have tried to alter the acid-base balance of their body before to try to make it so the drugs last longer, right? To give a little more bang at it for your buck. So people do lots of weird stuff in order to attempt to get better drug highs. So that's one of them. All right, so go to the next slide. So I mentioned urine is normally going to be mildly acidic. I mentioned kind of like 5 to 7 kind of range. Sodium bicarb is known to cause urinary alkalization, increase that urine pH. So we mentioned that sodium bicarbonate should have a net effect on those weak acids. So phenobarb is another drug as a weak acid. We could also potentially alkalize the urine, and that would help to increase the elimination. By increasing that pH, you're going to lead it to be in a weak acid to be more in a charged state, an unprotonated state. That's going to help to increase the elimination. So there are actual real-world examples where the Henderson-Hasselbalch equation does come up, and we use it for our benefit. All right, the next slide. Okay, so just looking at bioavailability, we're going to do a little bit of math here. Everyone likes math, right? Yep. Here, lots of resounding yeses. Great, awesome. Okay, so let's say we have a drug called propranolol. Okay, so propranolol is going to be a beta blocker. You guys know where beta receptors are predominant in the cardiovascular system? The heart is a big one. Do you guys remember which receptors those are? Beta 1, yep. Remember where else we have beta receptors? On the blood vessels. What type of receptors are there? Beta 2, remember what those do? Yeah, those actually vasodilate. So we can give propranolol. Oftentimes it's given for things like stage fright, because it can actually help to, when you get up and you're really nervous about giving a talk or something, like your heart's beating really fast, you can give propranolol to kind of help to blunt some of those effects. But let's say, for instance, we were giving propranolol. We're giving 160 milligrams, 1 tab daily. And so we said absorption, okay, propranolol is going to be a weak base, and so it's going to be highly lipophilic. And we know that's highly lipophilic because it's able to, based on the physicochemistry of it. But let's say it has a pK of 9.4. So do you think that it's going to have very good or bad absorption based on this? Very lipophilic. It's a weak base. Do you think it'll have an easy time absorbing through the GI tract? Yeah, so it should have pretty good absorption through the GI tract, especially when you get down into more basic medium. You're going to be shunting more of that weak base into the uncharged state. It's going to be much more lipophilic in those cases. So propranolol has a pretty easy time getting across the GI tract for the most part. If you're looking at the first pass effect, we can see that approximately 25% of that is going to end up reaching systemic circulation. So that means that how much of it is the liver metabolizing that drug before it gets to the bloodstream? like 3/4 of it, right? So like 75% of it is going to be metabolized just in the liver before it ever actually hits your system. So you're losing a lot of drug already. So that means if I were to give 160 milligrams, has very good absorption, but you have the high first pass, and how much of it would actually hit the systemic circulation? What actual milligram amount? So 25% of 160 should be 40, yeah, absolutely. So 40 milligrams is actually going to hit the bloodstream. That's the actual amount of active drug you're going to have circulating around in your system. Okay, everyone with me so far? Straightforward. So let's say we have an approximately 6-hour half-life. So you guys remember half-life is just the time it takes to cut that concentration of the drug down by 50%. And you guys remember when you have half-lives like this, is this zero order or first order kinetics? You guys are reaching back now. Last week was a long time ago. First order kinetics, right? Remember, zero order is constant amount of drug per unit of time. Think like ethanol, right? You're only going to do 20 milligrams per deciliter per hour. First order kinetics is going to be that same percentage of drug per unit time, right? So you can get half-lives like this where you can say, okay, the half-life is 6 hours. I know that if I have 40 milligrams in the systemic circulation right now, in 6 hours, it should be 20 milligrams. And in 12 hours, it should be 10 milligrams. And in 18 hours, it should be 5 milligrams. 24 hours, 2.5 milligrams, right? So again, the same percentage of drug for that 6-hour time frame. It's always going to be 50%. And so early on, I'm metabolizing a lot more drug up front, and then you're metabolizing lower and lower amounts as you go along because there's less drug there to metabolize. Okay? All right. So then looking at the distribution of propranolol, we can see how it actually is going to be circulated around the body, where it's going to be binding to. And so we see that approximately 90% of that circulating propranolol ends up being bound to some of these plasma proteins. So things like alpha-1 acid glycoprotein, it's another plasma protein that can be useful for combining with some of these weak bases. Okay, albumin is going to be another really important molecule for binding to drugs as well. So we'll find numerous examples where you can have drugs being bound up by albumin. Oftentimes they can be competing for the same binding sites, and that can lead to drug interactions as well. But in this case, let's say, for instance, that that 40 milligrams that made it to the systemic circulation, 90% of that's going to be bound up by that alpha-1 acid glycoprotein. So 36 milligrams is bound, and then 4 milligrams is actually going to be active. So that 4 milligrams, that's the physiologically active drug. That is actually what's able to interact with those beta receptors in the heart to slow down your heart rate. Okay, so it's not really a whole lot of drug based on that original 160 milligrams that we took. Keep in mind that this kind of 90% protein binding is going to be it's going to reach an equilibrium as you start to metabolize that free drug. More of that drug is going to come unbound off the protein in order to become physiologically active again, right? So again, the fraction that's physiologically active is unbound. That's what's able to interact with those beta receptors. Let's get this to work anymore. Still no projector. All right. Going to the next slide. Let's say, for instance, we had a 70-kilogram male. Let's say we gave him a dose of 160 milligrams, and we know that the amount in the circulation should be 40 milligrams. Okay. So based on this, let's say we did a plasma blood draw on him. We were going to go ahead and see what the level of propranolol is in his system, and it comes back at 0.14 milligrams per liter. Okay. So based on this, you can actually figure out what that volume distribution is for this drug. You can figure out what it is in liters, and you can also figure out what it is in liters per kilogram. You guys remember volume distribution? What is volume distribution? Yeah, it's how far out distributed does the drug get into the tissue, right? And so we mentioned that propranolol is lipophilic or hydrophilic. Just says very lipophilic, so that means it's going to like to partition out into the tissue pretty wide, right? And so this actually becomes a big issue, especially in older patients. We don't like to use propranolol in older patients because it's so lipophilic that it can cross into the blood-brain barrier. And so one of the common side effects these older patients will get is either like worsening dementia, or they get nightmares associated with it because it can have some effects up in the CNS. So that's one of these things you'll find there's certain drugs you just don't like to use. And a lot of older patients, you like to use much more water-soluble drugs because that means that it will have less chance to really cause a lot of those CNS effects. So in this case, if we're going back to our kind of basic equation that C0, that initial concentration, is equal to the dose of the drug that we have available divided by that volume of distribution, we can figure out what that volume of distribution is, right? So we can just rearrange the equation and figure out that VD in liters is going to be equaling dose divided by that C0. Okay, it's going to be the actual drug that actually made it into the systemic circulation at this point. So you don't want to use that original 160 because a lot of that already got metabolized by the liver. We actually want to use what's in the bloodstream already. Okay. So let's say we're going to so let's say we have VD equals that amount of drug in the body divided by that concentration. So we're going to have the X going to equal to 40 milligrams divided by that 0.14, and that's going to equal 286 liters. Okay, so that's a big volume distribution, small volume distribution. It's pretty big, especially when you look at it at liters per kilogram. So for this guy, we would go ahead and do 286 divided by 70, and you're getting 4 liters per kilogram. We say, what was the cutoff point for big versus small volume distribution? Pretty easy number. Right, 1, right? So 1 liter per kilogram. Anything above that is considered to have a large volume distribution. Anything less than that we consider to have a kind of small volume distribution. Things with small volume distribution like to stay within the systemic circulation much more so than things that have a large volume distribution. So propranolol would like to go into the CNS. It would like to distribute out into the fat tissue. It just has a much higher distribution than other more hydrophilic drugs would. Okay. See how these different kinetic issues are kind of coming back, and so kind of informing how we might use this drug, what kind of patients we might not want to use this drug in, etc. Right? So it's all kind of go into play when you're trying to decide like what drug is best for my patient, what dose should I be giving them, etc. Okay, so the next slide. So let's say, for instance, we took a 50 kilogram female now. Let's say we gave her a 120 milligram dose orally. We already know that the volume distribution is approximately 4 liters per kilogram, right? So we figured out what it was for that 70 kilo guy, and now we can transport that number, and assuming that's the population average, we can apply that to other patients now. And so we say, okay, well, this 50 kilogram female, she should have a volume distribution roughly of 4 liters per kilogram. So what would that concentration be in the plasma? Okay, so let's say we go ahead and take out our calculators. And so we say, okay, well, how much of that drug, 120 milligrams, is going to make it into the systemic circulation? Yeah, so we're going to do 120 times 0.25, so it's about 25% of that is actually going to make it into the systemic circulation, right? 75% gets hit by that first pass effect. So let's say we got 30 milligrams in the actual systemic circulation. So now we know what our dose is, and we can divide that by what number? So we take 4 times, and remember we had to apply it to the actual weight of the patient that we're dealing with, right? We need to make it more applicable just to her. So we're going to take 50 kilograms times 4 liters per kilogram. That way we only have liters there in the denominator, okay? So 50 times 4 is 200, right? So we're going to do 30 divided by 200, and what do you get? Yeah, you get 0.15. So essentially what you're doing is that you can take these kind of population averages and apply it to other patients to predict what type of levels you're going to get for those patients, right? To try to see, okay, well, is this dose going to be too much or too little for them? And so this is kind of the start of what we'll talk about a little bit later, which is going to be therapeutic drug monitoring. So we'll kind of go into that more detail as we get to that lecture. Okay, so again, you can see on the next slide here, the actual math is being done. You can see how we'll just take that 30 milligrams. You have to take the actual amount of drug that gets into the system. So like for testing purposes, if I said that, hey, I gave 120 milligrams IV, you would know that your dose in that case would be 120, right? Because the bioavailability is 100% when you give things IV, right? Versus if I give it orally, I will tell you, hey, the first pass effect is roughly this percentage, and then you can say, okay, well, this dose made it through. I know that I'm going to use that for my initial dose. Divided by that volume distribution for that particular patient, by multiplying that kind of population average, that 4 liters per kilogram times her weight, and then you get your liters there, and then just do milligrams divided by liters, and boom, you got your concentration, okay? And so that may signify, hey, this lady is going to be too high of a concentration for her, let's reduce her dose, or that's not high enough, let's bump her dose up some, okay? And so this can directly inform you like how we should be dosing this patient. When we do this a lot for our, especially patients who are getting much more kind of narrow therapeutic index like antibiotics, we do a lot for things like, if you ever hear of the aminoglycosides, we do it for things like gentamicin or amikacin. We do this for vancomycin, which is a very important drug for fighting gram-positive infections like MRSA, that methicillin-resistant Staph aureus. Like, this is a super important concept that a lot of times, the pharmacist may be doing for you, but in some places where you're working, where you don't have pharmacists available, you gotta do it yourself, right? And so you don't want to hurt anyone, you don't want to cause, ototoxicity or nephrotoxicity, so it's important to have a good grasp of these concepts. I know what you guys are thinking, hey, I'm just going to work somewhere where the pharmacists are, so that way I know I don't have to do it myself, but it's not always the right answer, right? Can't run away from your problems. Just kidding. Okay, so let's say the next slide, we have a 100 kilogram male. We're going to say the concentration in the plasma, we were able to measure that, was 0.05 milligrams per liter. And we're going to say that, okay, well, we know that the volume distribution is roughly 4 liters per kilogram. You can actually go back through and see, okay, well, what dose did this patient receive? Okay, so you look to see, let's go ahead and do the math here again. So you can say, okay, well, I know my C0 is going to be 0.05. what I can do is multiply that by the volume of distribution, and it should give me my initial dose. So I can do that 0.05 multiplied by, what number would I multiply by? Should be 400, right? Because I do 4 liters per kilogram times that 100 kilogram male, so we do times 400, and you end up getting 20. Okay, so we get a value of 20. That means that's what was actually in the systemic circulation. So based on the fact that we know that only 25% of that made it through the GI tract, we can say, okay, well, we're going to divide that by 0.25. We end up getting a dose that patient receives at 80 milligrams. It's less common you do that kind of calculation, but just kind of show you how, as long as you have 2 of the variables, you can always figure out the third one, essentially, right? But always take into account the route that you're administering it, take into account what that bioavailability could be. And again, a lot of these values are going to be given to you when you look it up in drug references and whatnot. So again, on the next slide, just kind of showing you the math there so you can get the total amount. 80 milligrams would be that amount that the patient would have taken orally in order to get that concentration there. Next slide. So let's say we're going to put it all together. Let's say we have a new drug, it's called sarcastanol, for patients who are excessively sarcastic. I don't know if you know anyone like that, but let's say it's a weak acid. There's a pK of about 5.4 and a bioavailability of about 90%. We know, based on population averages, based on the studies we've done, has a volume distribution of roughly 0.2 liters per kilogram, and we're going to be dosing it at 500 milligrams every 6 hours. Okay. So based on this, we know it's a weak acid. Where do you think it's going to be absorbed best? In the stomach. It might be absorbed. Yeah. So again, when you think about it, when it's in a more acidic medium, when the pH of the solution is below that pKa, you're going to be, if you actually did the Henderson-Hasselbalch equation, you would see that you're going to have a higher proportion of drug that's going to be in that uncharged state, that protonated state that will allow for better absorption of that drug. So maybe better absorbed, in the acidic medium of the stomach, or maybe slightly once it gets into the small intestine before it's really had a chance to dilute out. But as you get to more and more basic solutions, it's going to have a harder time because it's going to be more protonated, or it's going to be more in a more charged state, unprotonated. Slide. So let's say after 500 milligram dose, how much of it do you think actually gets absorbed into the systemic circulation? Is that 450? Why is that? 90%? Okay, so, right, so 90%, so 0.9 times 500 should be 450, so that we get 450 milligrams. Now, what effect do you think that taking calcium carbonate, or Tums, common antacid on the market, would have on absorption? Say, for instance, calcium carbonate would be a base. What do you think that would do to the absorption of the drug? You decrease. Why? Yep. So you're dissolving. Basically, you're starting to neutralize, and that's what we take Tums for, right? Because it neutralizes the stomach acids when we have reflux. So by neutralizing those acids within the stomach, you start to raise the pH. Right, we said it's a weak acid already, so as you start to raise the pH, you're going to make it so that the weak acid is going to be much more in a charged state. It's going to be in the unprotonated state. It's going to reduce the amount of absorption you have there. Okay, so these are the kind of things we have to think about. Like, okay, well, what other drugs are the patient taking that could be affecting the absorption of these drugs that I'm prescribing? And again, do you have to have a prescription to get Tums? Oh, yeah, you can just buy it and take it, and that's a problem we run into very frequently with patients, is they're not always forthcoming with what other drugs are they taking, or they don't look at Tums like drugs. Like, they just think, oh, guys, I take when I have reflux, right? So it can be a big thing. Always make sure you're asking about over-the-counter meds that they're taking, other kind of supplements and whatnot that could be having a reaction here. Okay. Next slide. Let's say that we have, what would be the expected serum concentration after a 500 milligram dose in a 70 kilogram male? So what do we think? So we know our dose. We gave 500 milligrams. We've said how much of that should be getting through to the systemic circulation. 450, right? So we said 90% bioavailable, which means that 90% of that's going to make it through. So 450 is going to be our dose there. And what will be our volume distribution? What did I say on that last slide? I think you can't see it anymore. Yeah, so 70 times 0.2. So I do 70 times 0.2. You get what? 14, right? So you get 14 liters is going to be that patient's volume distribution. So I would do, and I said 0.2, so does that mean that the drug has a high or a low volume distribution? Right, it's going to have low, so it likes to stay more in the central circulation, right? It doesn't like to partition out to that tissue there. So if I did my dose of 450 divided by 14, should get a C0 of 32 milligrams, right? So 32.1 essentially. So you should be having a lot more drug kind of sitting there in the systemic circulation. So when you measure it out of the plasma, most of it's going to be there, right? So that's why you see those higher concentrations in the blood when you're dealing with a low volume distribution type drug. Okay? Yes, ma'am. Yeah, it would tend to be a little bit better absorbed in more acidic mediums. Propranolol? Yep. Mm-hmm. No, that would be better absorbed like in the small intestine, right? So after you had a chance to dilute out all those acids and, yep, exactly. So some drugs, they'll get completely destroyed in the stomach acids, and that's where we actually have to like coat them with a coating that is actually acid resistant, and it will not dissolve until it actually gets into more basic medium. So like it doesn't actually dissolve the coating on it until. So if you ever see like Nexium or something like that, if you get it over the counter, if you open up the capsule, you'll notice all these little beads in there, and basically those are just acid resistant beads that don't dissolve until they get to that basic medium and allow the drug to be absorbed when it gets dissolved off. So lots of little tricks we can do to make so drugs can get absorbed a little bit better. So I mentioned volume distribution much lower than something like propranolol, so a lot more of that drug can be measured right there in the bloodstream. Okay. So let's go to the next slide. Let's say a 45-kilogram woman was taking sarcasinol, and now she's experiencing excessive amounts of sarcasm. She has overdosed on this drug. What do? Let's say her serum level is 75 milligrams per liter. What dose do we think she took? So knowing that C0 equals dose over VD, so we know that for her, 45 kilograms times, so 45 kilograms times 0.2 should be our volume distribution. So we know for her, she's roughly 9 liters. Okay, so we're going to take that 9 liters, you can multiply it by that 75 milligrams per liter, equals 675 as her dose. And then we said that it's 90% bioavailable, so we can divide that by 0.9, and I'm getting 750. So she took basically a time and a half what the normal dose would be based on the normal dosing recommendations, right? So again, think about the math should be there in the note section so you can kind of see that. That makes sense for everyone? The math on the test will be super easy. You won't even need a calculator, probably just some scratch sheets. It'll be like not anything like the value you get is like 32.13. Like it'll be pretty obvious math. Okay, so don't stress that. We'll go over it in the review as well. So that last one, so her dose would have been 750 that she took, right? Because then it gets 90% bioavailable, so 90% that makes it through, and then divided by her volume distribution, you end up getting that 75 milligrams per liter. A lot of drugs are also expressed as micrograms per mil, right? But we know that's the same thing as milligrams per liter, right? So it's just a factor of 1,000 either way. So if you see micrograms per ml, milligrams per liter, both the same thing essentially. Because remember, that's what actually made it through the first pass effect. And we said it's 90% bioavailable. So if we were to take that number and divide it by 0.9, you'd figure out what the total amount she actually took to account for that 10% that was metabolized in the liver. Okay. Okay, sarcasinol is not a real drug, though. Sorry to tell you. So. Say it again. Mm-hmm. Yeah, because if you're using that population average, so saying it's 0.2 liters per kilogram, you multiply that by her weight, and that way you get that patient's particular volume distribution, right? Because we want to make sure that we're keeping our units straight, and so we want to have C0 should equal milligrams over liters, so we make sure all of our values get into those units there. So if I have liters per kilogram, I multiply that by the patient's weight, kilograms cancel out, and you have your liters left over. So you can do some practice, you can kind of make up your own little examples and try that out with your friends, you know, it's a good time for a Friday night, right? Just kidding, it's not. So next slide, let's say we have a 45-year-old male who takes 500 milligram dose of sarcasinol and has a plasma level of 20 milligrams per liter. How much do you think that patient weighs? Again, not something we do super often clinically, but we can at least work out the math and see if we can figure out what that would be. So we know that the dose that he gets into the systemic circulation, we already said would be 450, right? It's 90% bioavailable, so we'd have 450 in the system. So we know what our dose is. We know what our C0 is, right? And so basically what we can do is we can kind of flip that over. So we can take our dose divided by our concentration. So we say 450 divided by that 20 and you get 22.5. So that was basically the patient's volume of distribution. So now what we can do is divide that by 0.2, and we know the patient weighs roughly 112 kilos, or 12 and a half essentially. So again, we're just solving for different variables, pretty basic algebra in those situations, right? Everyone with me? Fantastic. Again, math will be pretty easy on the test. We don't even need calculators, just scratch notes will be fine. Okay. So on the next slide, we're talking about bioequivalence again. So again, this is when two different drug products contain the same active ingredients, identical in strength, concentration, all of that. So again, really important for same drugs with different manufacturers. Oftentimes you'll have patients that will come up and say, man, only the brand name works for me. Only the brand name is going to work for that. And you're like, well, it really shouldn't be the case, right? Because in order for generics to be put on the market, like they have to show bioequivalence. They have to show they're getting the same type of levels as the brand name drug. So really there shouldn't be any difference. Now, certainly there are some differences in as far as what other products are mixed within that pill or that capsule, whatever it happens to be. They can have different coloring agents, different fillers, things like that. But the actual active drug has to show they get the same type of levels between the generic and the brand name drugs, right? So they really should be working almost exactly the same. Not to say that some people may not be, placebo effect is a very strong thing, as you'll learn in your clinical days, that just people thinking, hey, I'm taking the brand one, this is going to work better for me. Sometimes that can have a pretty strong effect on that. Okay. Go to the next slide. You can look at an example of a drug called bupropion. This is a drug we will use occasionally for depression. It's actually getting a lot of traction now, being used for things like helping to quit smoking. Sometimes can also be used for weight loss in some cases. But you can notice here we have two different forms. You have that green line there that is going to be for a kind of a generic form, and then the red line is going to be the brand name form. And basically what they have to show is that within a certain margin of error, that they're going to be getting the same kind of peak levels, the same time to get to that peak level, and the same type of dissolution characteristics. So you can see basically they would take patients, they would give them the drug, and they would measure serial levels for them to see where their values actually end up at. And so this one may be considered to be, okay, this would also be considered bioequivalent because they have roughly the same, again, they don't have to be exact, there's usually a margin of error that they can shoot for to be considered bioequivalent. Okay. So on the next slide, we mentioned that pharmaceutical equivalents are going to have the same active ingredient, same dosage form, same route, same strength, but this is where they can differ, like in their shape, the scoring. When I say scoring, what does that mean? So if you look at a tablet and you notice there's like a line down the middle of it, so you can break it in half, that's scoring essentially. Release mechanisms, the packaging, the excipients, all that stuff can differ, but the actual pharmaceutical product itself is going to be the same there. So those can be pretty much interchangeable for the most part. Looking at pharmaceutical alternatives, you can have the same therapeutic drug, but it may be a different salt, a different ester, or some sort of other complex. So a good example of this would be tetracycline, which is an antibiotic. You can have the tetracycline hydrochloride versus tetracycline phosphate complex, right? Sometimes you have to adjust the dose in order to take into account those different salt forms. Another really good example of this would be when we're giving calcium to patients intravenously. There's two forms we have primarily. We have calcium chloride, and we also have calcium gluconate. And so even though both of them come as the same concentration, they both come in a 10% solution, they both contain 1 gram of their respective salts, the actual amount of elemental calcium differs between the two pretty widely, because a gluconate molecule is a lot bigger than a chloride molecule, right? So that means that you have to end up having a conversion there to make sure the patient's getting the same amount of calcium when you switch between the two different products, right? Okay. Next slide. So therapeutic equivalents, again, they have to be pharmaceutically equivalent first, and they're going to be expected to have the same clinical effect and the same safety profile. You also have to show some other additional things as well to be considered therapeutic equivalents. Have to show that they're going to be safe and effective. Pharmaceutical equivalents already, that's kind of their baseline, what they have to meet. They'll have identical amounts of active drug, the same dosage form, same route of administration, and they have to be considered bioequivalent. So they have to show those studies to show that they're going to get pretty much the same graphs between the brand and the generic product. So on that next slide, there's used to actually be a book, they call it the Orange Book, but it's basically supplied by the FDA, and this is basically a good reference for, on the pharmacy side, to show products are going to be bioequivalent. So this is the things where we sub out a product one for another. This is what we are kind of referencing in some cases, and this book kind of tells us, okay, these products are going to be bioequivalent to one another. So if you go to the next. You'll see that nowadays it's published online, so it's all available there. So we still call it the Orange Book, even though it doesn't actually get published as a book anymore. These therapeutic equivalents will be given via these codes, essentially. And so anything that has an A rating means that we will have therapeutic equivalents. That means I can interchange things. So even if it's AA or AB, I know that if I give this product and it's AA rated to this other brand product, I can switch them out, no problem. The patient should not have any difference in the amount of drug that they're actually getting into the system. Anything that's B rated is not going to be therapeutically equivalent, which means I cannot interchange that out, because there could be a difference in how the drug is being absorbed, how quickly the patient gets to peak levels, so I cannot really do that for those patients. Okay, yes ma'am. It has to do when they were doing the testing. Honestly, I knew it at one point, but it's not super clinically relevant for us. Mainly what we do is if we consult this, we'll say, okay, is it A-rated? If it's A-rated, then I know I can switch them out. There's probably other pharmaceutical nerds out there who will be more interested in that part, but I'm not going to make you guys look into that. Just know if it's A-rated, it's good to go. So on the next slide, you'll see just an example. This is a thing I pulled up where you're looking at two different propranolol products. Notice how they're BX rated, so that means I could not actually switch those out based on the different actual doses that you can see there. But lots of other ones on the top of that list, you can see like hydrochlorothiazide and propranolol. It's a combination drug. That one is AB rated, so I can switch any of those AB rated products out for one another, and it would be totally fine. You know, a patient would not experience any difference there. I could, yeah, as long as it's A rated, then I'd be fine. Yeah, but if it says B, then I can't switch it out. Yep. Okay. So any questions on that? All right, I'll give you guys a 10-minute break. We'll come back. Hopefully the projectors are going to work. That'd be nice. Okay, so we're going to go to the slide right after the geriatrics one. So we will consider geriatric patients anyone who's greater than 65 years of age. Okay, we know that we have a pre-aging population. So say like in 2015, we had around 324 million people in the U.S., and we see that about 15% of those or so are going to be greater than 65. That's probably going to be getting larger as the population tends to get older in general. Or depending on how things go with healthcare, maybe that population will shrink. Who knows? We'll see. Just kidding. Political. No. U.S. life expectancy, though, currently is 79 years, and again, hopefully with medical advancements, that may get even better. We'll see. The next slide. So it's really important when dealing with geriatric patients that they can be prone to certain changes. They can be prone to certain things that may dispose them to, adverse side effects or to failures of therapy. And so assessing a geriatric patient can be really, really important. So we like to focus on patients, and this is just one example of a geriatric assessment you can do. And so we'll kind of look at some of the points and how it kind of can reference back to their drug therapy. Because again, looking at older patients, do you think they're probably on very few number of drugs or a lot of drugs? Probably a lot of drugs. Like go to any nursing home and go to like a brown, like just say, hey, we're gonna do a brown bag event, and they will bring out meds from like the 1800s and all kinds of bad stuff. So you said they haven't been on in like 60 years, and they're like, yeah, I'll still take this. And it's like, okay, this has been expired for a long time. But anyway. So the really big thing is to focus on their functional status and also on quality of life. So again, not always is more meds going to be better for these patients. Sometimes you want to look on how you can kind of try to trim down and reduce things to try to increase their ability to be successful. So we're looking at functional status, we're looking at their medical status, psychosocial capabilities, any limitations they have with this. And also, it's really important to look from an interdisciplinary team, right? So looking to utilize a nutritionist, looking to utilize pharmacy, to utilize nursing, the providers, like everyone has to get involved to make sure that we're doing right by the patients to make it kind of best for them. The next slide, we'll talk about their activities of daily living. Obviously, they can have very basic ones like bathing, dressing, toileting. A lot of these patients may not be able to keep up with these depending on kind of how their functional status has been diminishing over time. Obviously, things like taking medications, it can be very difficult for some of these patients. We have issues with dementia or memory problems. Like it can be very difficult for them to keep up with even the simplest of medication regimens. Also, they have more advanced ones as you go along, and we like to keep them as functional as possible, but it's not always going to be the case. But sometimes things like medications can help them to become more functional. Sometimes you find that medications are on to lead them to be much less functional. Okay. Next slide. So again, you can see how the nutrition section can be very, very important for these patients. Looking at how inadequate nutrition can be affecting their drug therapy is important. So things like, limited dentition or ill-fitting dentures, they're not able to take in a lot of food very well. Their nutritional status is going to diminish, and that can make them have even less physiologic reserve to deal with things like the medications that they're on. Oftentimes they'll have decreased appetite, either due to loneliness or due to depression that maybe is not being treated sufficiently. If they're on appetite-suppressing drugs, things especially like stimulants and things like that can actually depress their appetite, make it so they're not eating enough. Certainly things like medical conditions can affect them. Things like constipation, especially with a lot of patients being chronic pain sufferers, they're going to be on opioids. Opioids cause constipation. It's a huge, huge problem for that. Cancer, dementia, all of that can be affecting their nutritional status, if they just don't think to eat. Also, financial resources can be huge as well. So can the patients actually afford to even feed themselves, much less take care of their other kind of medical needs there? And then just looking at limited access to food or ability to prepare meals, why things like Meals on Wheels is really important for them, make sure, or having some sort of resource so they can actually get the food that they need. You want to ask a pretty detailed assessment of kind of what they've been eating, what they've been drinking over the past, say, 24 hours or so, or kind of what they do on average. So, for instance, like, talking about foods, if a patient is on something like Coumadin, we said Coumadin or warfarin is a drug that's an anticoagulant, and it works to block the effects of vitamin K in the liver. And we said vitamin K in the liver is really important for forming what? Yeah, several of our clotting factors are very primarily made within the liver, and so we know that warfarin can inhibit that. We said that if a patient gets a lot of vitamin K in their diet, that can affect that. It can make the warfarin less effective. Or if they stop eating vitamin K containing foods, the warfarin becomes too effective, and they can lead to a bleed. So we run into this problem frequently when you have patients who, especially like in rural areas, like Putnam County, patients ate a lot of collard greens, and sometimes that would lead them to require very big doses of warfarin. And then when they were to, say, stop eating that all of a sudden now that dose is way too big for them, right? So, yes, let's come back on. So anyway, so it's really, really important to make sure that you are assessing their diet, kind of see what the average is for them. Drinks are important because elderly patients are more likely to get dehydrated over time, so that can be a big problem, especially with medications that get eliminated through the kidneys. Right, so if they're dehydrated, you have poor kidney flow, that can lead to some issues where they're not clearing drugs as well. So hydration status is really important. What we'd run into in a lot of cases in the ERs, you'd have patients who were on some of these medications that get cleared by the kidneys. They would end up getting sick, they would get dehydrated, no one's really checking on them like they should be, and then they hold on to all these drugs, and then they get very, very toxic off of that. So it's kind of a major problem we run into from the nursing home side of things. Also look at supplements and vitamins. Why do you think that's important? Yeah, interactions are huge. So for instance, they're like, oh, I'm feeling kind of glum lately. I'm going to go ahead and start taking the St. John's wort for my depression, right? Okay, well, that could have some pretty significant interactions based on the other medications that they're taking. So it's really important to ask, okay, what type of dietary supplements are you taking? What type of vitamins? Make sure you're kind of assessing their health literacy and make sure they kind of understand what you're talking about when you say supplements or when you say vitamins, what they're referring to. So again, look for things like, the eating, how many meals a day they're eating, what kind of fruits, vegetables, milk that they're getting in. Milk, I said, is really important, not only for, osteoporosis-prone patients, but also because it can bind up medications. So these are all things you're going to be assessing for these geriatric patients. So anyway, also check for alcohol consumption. This can be really important. Assessing for, are they having an issue, like, you have an elderly patient that came in for a fall. Okay, well, did they fall because of just purely their medication, or do they have orthostatic hypotension? Was it related back to alcohol use? That could be a problem as well. So one of the things you can assess there. Getting money, if they're eating alone most of the time, are they able to feed themselves appropriately? These are all things you want to consider. Also be looking at their weight over time, be assessing if they're kind of gaining weight, losing weight, because that can be indicative of kind of what's going on in their nutritional status. Okay. So then looking at continued assessments, looking at laboratory tests. These are super important to be actually monitoring over time because it can directly affect your drug therapy. So for instance, looking at a CMP or a complete metabolic panel, this will help us to look at things like kidney function, right? Because a lot of patients will get put on drugs at one dose. They need to be renally eliminated, and they will find that over time, kidney function diminishes, and they never go back and assess that drug again, right? So that can lead to toxicity if they hold on to those too much. Looking at things like protein like albumin. Albumin is really important because if you don't have good nutritional status, your body's not really dedicated to making new proteins, and this albumin is going to go down, and that can be important for binding of drugs. So if drugs are tightly bound by albumin and now you don't have a lot of albumin around, you have a lot more of it free floating around in the blood, it can lead to toxicity. We said free drug is physiologically active, so we can see where that can be a problem for those patients. Looking at acid-base status as well, again, could all be affecting things like drug absorption or drug elimination, so it's good to assess. Liver function obviously needs to be assessed as well, especially for patients who have maybe chronic alcoholics or if they have chronic hepatitis or cirrhosis or anything like that. You need to be assessing them to make sure that they are clearing drugs that are hepatically eliminated appropriately whenever there. And then some of these other ones you're going to be monitoring just for things like just the effectiveness of some of the drugs you're giving. So things like you're familiar with hemoglobin A1C. What is that? It's kind of like an average amount of glucose that your hemoglobin is carrying around in the bloodstream for roughly a 3-month period or so. So this is really important that when we are assessing diabetic patients, in addition to just kind of assessing their fasting blood glucose or their glucose after eating, we also check their glycosylated hemoglobin A1C, and that will tell us basically what their average the average glucose levels in the blood have been based on the red blood cells. So that can be a very, very useful test you're going to be checking there. So you can see, like, okay, well, you say you're taking all your diabetic medications. Is your A1C improving, or is it getting worse? So is it the diet we need to address, or are they even taking their medications? Maybe they couldn't afford them and they stopped taking them. Who knows? Also, checking their CBC, you can look for things like infection or anemia, all of that. B12 levels, we mentioned if you don't have enough B12, what can happen? Yeah, you get that pernicious anemia that can happen there. So again, want to make sure the B12 levels are good. Looking at urinalysis is going to help us to identify UTIs, things like that. So all these are important to assess over time, right? You want to look for trends in some of these to make sure that the patient is staying functional, or if they're losing function, you can adjust drugs as necessary. Okay, so there's a term polypharmacy, and so this is basically going to be referencing the use of 5 or more drugs on a regular basis at any given time. Some of the reasons for this: one, patients are living longer, so they're developing more disease states that need to be treated. You're also going to find that as they get sicker, they're developing more of these chronic diseases that requires more medications. And also, when you're looking at evidence-based clinical practice guidelines, usually if a patient has hypertension, you have a list of drugs that you should be using to treat their hypertension, right? If they have previous MI, here's the drug you should give to reduce their likelihood of mortality over the next 10 years. So you can find that these, based on these different guidelines, you can end up on a laundry list of medications, some of which may be antagonistic to one another, some of which may be synergistic, leading to toxicities. So it's really important to kind of assess kind of what they're on, what your goals are going to be, to make sure you can try to trim down that list as much as possible. Okay. Also, one of the problems you run into is that do people just normally, like older people, do they see one doctor only? Right? No. Oftentimes we'll see several subspecialists. And so if Dr. A provides this, and then PAB prescribes this, and then their other specialist prescribes this, no one touches each other's medications. It's kind of a chronic problem you run into, to where they say, well, if someone else prescribed that, I'm not going to touch it, even though I can pretty obviously see this is the wrong drug for you, or this is having a side effect that you're experiencing there. So patients end up on these huge lists of medications where people aren't really communicating with one another. And so you guys, especially if you're on the front line of it, say from like the family practice standpoint, you can be kind of that person that goes, wait a second, let's talk with all these providers, let's figure out what's going to be best for the patient and try to trim down on some of these medications. So again, very frequently that's where you're going to run into, where you'll see a patient with 15 meds on their list and they're all prescribed by somebody different. Right? So it can be a huge, huge problem. So again, some of these causes, looking at age and comorbidity, you see about an 8% increase in the number of medications with each additional increase. So for example, if you had a patient with osteoporosis, osteoarthritis, type 2 diabetes, hypertension, and COPD, it's not uncommon to run into patients like this. They're going to have 12 different medications that they're getting 5 different times a day. So how easy do you think it is for them to keep up with that? I could not keep up with that. I'm a pharmacist, right? So like, think about, they have memory impairment issues, they have dementia, like all of that's going to make it very, very difficult unless someone is actually giving it to them. With evidence-based guidelines, you're finding oftentimes they're adding more medications onto a list, or at least changing what medications they recommend. And then with hospitalization, this is a big problem as well. Patients come into the hospital, very frequently they're going to be leaving the hospital with more prescriptions than what they came in on. Okay, try to prevent that rehospitalization as best they can, but that can lead to several new medications for these patients. So again, looking at consequences, we've talked about adverse drug reactions. As you add on more medications, you're more and more likely to see adverse drug reactions start to pop up. Some of the big things you worry about are going to be falls associated with these patients. So if we're giving antihypertensives, anything affecting the cardiovascular system or affecting the CNS, anything causing CNS depression, anything like that, you're more likely to have falls. And once these patients fall, especially with orthostatic hypotension, what are they likely to have happen? break a hip or they break a leg or something like that, and then that can be devastating to these patients, because again, they may very well never regain that functionality again, and that is a huge link to mortality and morbidity for those patients. So this is why we really want to make sure that we're watching for fall risk. We are making sure we're assessing patients. A lot of times when you're dosing medications for these patients, you want to start low and go slow. So start at lower doses and you gently titrate up to see how they tolerate it. Otherwise, you're more at risk for these kind of falls. Okay. Also, decreased compliance. The more meds they're going to be on, the more complicated the regimen is, the less likely they're going to be actually stick with it. Okay. So decreased compliance can be related back to that complex dosing schedule, multiple medications. A lot of times if a drug is too expensive, they're just not going to buy it, right? So you prescribe something, they say, hey, yeah, of course I'm taking it, it's just not working. But really they can't afford it, right? Because oftentimes they may not be all that truthful with you in some cases. Or they either don't buy it or they'll just skip doses. So if it's one tab one time a day and they're like, well, I can only afford this once every other month, I'm just going to take one tab every other day. And so you think it's not really that effective, and really they're just not taking it as prescribed. Okay. Could be lack of support, either formal or informal. So sometimes they need someone to actually make sure they're taking the medication. So either a caregiver, whether it be home health care or something like that, that ensure they're actually taking it. Obviously, their mental decline or visual impairment, they can't remember to take the drug, or if they can't see what drug it is, that can lead to decreased compliance as well. I'll never forget one lady who she was blind as a bat. Had 15 different drugs that she was on, and she just had these huge symbols marked on the top of the pill bottles. And for whatever her system worked, so where she could, even though it was like kind of a red blur, she knew that was her metoprolol. She looked at this green squiggle and she knew that was her hydrochlorothiazide. She knew it perfectly, but not every patient is going to be like that, especially with this kind of mental declines. Other things, decreased swallowing ability. This is where things like transdermal medications or sublingual medications can be really useful, especially if they have really poor ability to swallow meds. So think about patients who have had previous stroke and have dysphagia, things like that. Like that can be very problematic for them. So oral medications or liquids might be a better option for them. Transdermal medications or liquids might be a better option for those patients. They'll also tend to have decreased venous access as they are, especially if they're kind of frequent visitors to the hospital. You get stuck more and more, that scar tissue starts to develop. It can be more difficult to get actual good IV access from those patients. And finally, just look at their willingness to comply with treatment, right? Over time, you may find that they don't really care to treat their hypertension. If it's not bothering them and they're already 90 years old, does it really matter that they're on the recommended guideline medications? Sometimes no. If they're not really expected to live that much longer, they may say, well, I'd rather not have the side effects of the drugs and just kind of improve the quality of life. So you always have to have those conversations to see what are the goals of the patient, what are my goals, and make sure those kind of line up together. Okay, so sometimes no treatment is going to be the best option for those patients. Okay. So we'll consider those patients that are end of life to have less than 6 months to live. And so when you're treating these patients that are greater than 65, it's important to prioritize and to tailor that treatment plan to what their goals are going to be, right? So if they know they have 6 months to live, again, do they care if their diabetes is out of control? Probably not. They're going to die anyway. So it's like one of those things where if the side effects of the drugs are worse than no treatment, then they might just opt for no treatment in those cases, right? So you have to have that conversation. Looking at kind of the spectrum, so with the chronic disease, you can see the disease progress here that occurs, and normally you're looking at life extension when you're treating a disease, trying to make sure you can extend life as long as possible. On the flip side of that, you have this palliative treatment. So if you guys familiar with that term, palliative care? Right, so it's kind of end-of-life care, so it's kind of the thing to try to make their life as comfortable as possible right up to the end. So again, early on, you're going to be treating with the intent of extending life, but you're going to get to a point now where you're saying, well, there's not really a whole lot of life left to extend. Let's go ahead and try to make their quality of life as good as possible, and that's where palliative care really comes into play. And so like we run into this a lot with like my wife. She did her residency or second-year residency in pharmacy in pain management, and so it's a huge issue because she did at the VA. There's lots of vets out there who are ready for palliative care, and so trying to make sure you optimize their pain regimen, making sure things like they have good bowel regimens, make sure they're not constipated because that can be a huge effect on quality of life. All these different things to make sure they're as comfortable as they can be when they are shaking loose this mortal coil, right? And then afterwards, obviously, it's a lot of care focused on the patient's family, things like depression afterwards and things like that. You can try to make sure you assess those guys as well. Okay, so just normal kind of changes that we see with geriatric patients and how we can adjust our drugs to combat these changes. Typically cardiac, you're going to be seeing that their arterial pressure is going to rise over time, so typically systolic pressure is going to rise. They will have some impedance to left ventricular ejection. We mentioned over time, especially with kind of chronic blood pressure issues, the heart is trying to compensate for that by being harder and stronger to go against that afterload issue, right? We're going to see that remodeling that happens there, where the ventricles are going to get more kind of fibrous. It's going to have less compliance. It's not going to be able to kind of be stretched quite as much. And so all those changes lead to kind of poor left ventricular function. That's eventually what kind of leads to CHF, or that congestive heart failure. Also potentially see reduced heart rate associated with those kind of age-related changes. As far as renal goes, you typically are going to see a decrease in renal function that happens fairly steadily. Some patients more steadily than others. Some of them are going to be pretty precipitous depending on their disease states. But you should see declines in GFR. You guys remember we talked about that before, that Cockcroft-Gault equation that we use based on their serum creatinine, based on their weight and age, we can figure out what their renal function is going to be. But basically, they are going to have a decreased ability to really eliminate some of these medications. They're going to have a decreased ability to maintain good acid-base status. If you guys look at the last lecture I put up for physio, we talk about the kidneys being really responsible for helping to maintain acid-base status from the bicarbonate situation, helping either reabsorb or excrete bicarb. They lose some of that ability as well, so more likely to see acidosis or alkalosis in those patients. Just kind of a graph just showing, and I'm sorry for anyone who's already 30 in the room, me included, but yeah, we're already starting to decline, as you can see here. GFR, cardiac index, maximum breathing capacity, all this is going to be declining pretty steadily on towards the end of life. Okay, so it's just naturally going to happen. We're all going to die someday. So we can figure out like the brain in a jar kind of technology. That would be ideal, but not quite there yet. Anywho, looking at some other GI effects that can change over time, looking at the stomach and the duodenum, decreased hydrochloric acid and pepsin secretion. You guys know what pepsin is? It's an enzyme. It's useful for digesting a lot of some of the food and things coming into our GI tract. We'll talk about that in GI later on in physio, but basically you can see decreased, basically just breakdown and metabolism of the food in the stomach. You can see decreased gastric emptying. That can be termed gastroparesis if they're like having vomiting and it looks like it's still whole food they haven't really digested. Sometimes you can see that, especially like diabetic patients. But gastric emptying is slowing. That slows down things like drug absorption as well. It can be a problem. And then you'll see decreased absorption in the small intestine, decreased motility in the colon, decreased just kind of production of proteins and enzymes within the pancreas as well. So things just really aren't getting absorbed as well. And so it's easy to see how kind of their nutritional status can take a hit as they get older and older. Okay. Big thing from our standpoint from pharm is going to be the liver. Typically, you're going to see decreased blood flow, decreased metabolism, and elimination of those drugs. All right, so looking at specific pharmacokinetic changes that occur with these patients, on the absorption side, you don't really see a ton of major changes that occur here, but you do see dietary changes that can happen. So for instance, you know, with an older lady and you were trying to prevent osteoporosis, you tell her to drink tons of milk, right? We said that is going to be it can potentially bind up a lot of other medications, right? So you have to look for those calcium interactions. If you think about things like, you know, them becoming anemic, you want them to take iron. That can also bind up a lot of medications. So you have to be careful with those sort of things. They're also more likely to use a lot of OTC medications, so things like antacids. We already mentioned how that can affect drug absorption. Things like laxatives, which may alter the GI transit time, right? So laxatives being what type of drug? What do? If you're constipated, basically speeds things through, right? So trying to increase urge for defecation and going to the bathroom. So we mentioned that impaired gastric emptying. That's going to be more predominant with diabetics when they have gastroparesis. A lot of it has to do with kind of the nerve damage that happens when you have that kind of chronic high blood sugar. But you'll get into that in a different class. Looking at drug distribution, this is where we're going to see a lot more changes related to the elderly patients. So typically, they're going to have reduced lean body mass. So typically, going to be losing muscle mass and total reduced body water. So again, dehydration can be a much bigger problem for these patients. So if you were to look at, say, like a young 20 to 30-year-old patient versus an older patient, comparing things like their body water. So we mentioned, or we will see that when you look at total body water, about 60% or so is going to be making up a young adult patient versus maybe only about 50% or so. That means if you have a drug that's very hydrophilic, that likes to stay in body water, it's going to be more concentrated, right? Because you have less body water for that drug to distribute out to. Looking at their lean body mass, you can see that's going to be decreasing over time, so less muscle mass, which can affect things like your serum creatinine. Less muscle means you're not producing as much creatinine. Their body fat percentage is typically going to increase. So you're kind of comparing women and men. You can see how it's going to have a pretty significant increase there. So adiposity is going to be going up. Serum albumin, I mentioned that can be important for binding to different drugs. This should be heading down, right? So especially if their nutritional status is taking a hit, may not really be producing as much albumin, which can lead to lots of drug interactions. And then just hepatic blood flow, kidney weight, all that should be going down pretty significantly as you get older and older. So specifically when we're looking at that protein binding, so decreases in serum albumin, again related to nutritional status. So as they're not eating very well, the body's not really focused on making proteins, so albumin takes a hit. And we'll monitor that in these patients to see what their nutritional status is like. This mainly is going to be affecting weak acids, so things that would normally bind to albumin. If they have less albumin to bind to, that means you have more free drug, more of it's available to interact with the receptor, more likely to see pharmacologic effects. That means that even though you're given the same dose that you would have given them, say, 10 years ago, they're going to be much more likely to suffer toxicity because of that, right? Because that free fraction is higher. Sometimes you actually see increases in certain proteins. We mentioned that propranolol in the last lecture actually binds to alpha-1 acid glycoprotein. They actually see some increases there. But clinically, you don't see as much interactions there. Albumin's the primary thing we were concerned about. As far as kidney goes, you're going to see decreased clearance, so it means you're going to have reduced renal function. So for things that are primarily eliminated by the kidneys, you're going to have higher levels of them if you do not take that into account and adjust their dose. Some patients may need to have a dose just reduced and keep it at the same interval. Some people need to have the dose reduced and have it given less frequently. So maybe give a drug every 24 hours instead of every 12 hours based on the renal function. And you'll find that in those references, if you go to LexiComp or go to Micromedics, those will be on there to say, hey, if their renal function is between this and this, here's how you dose it. If it's lower than that, here's how you dose it. But you should see decreases in serum creatinine. May not be proportional to the actual decrease in their creatinine clearance, right? So they're losing more muscle mass. They're not able to produce as much creatinine. So even though you may have a 90-year-old lady who weighs maybe like 40 kilograms, her creatinine may only be 0.6, which looks really good. I know her kidneys are not actually functioning that well, right? A 90-year-old is not going to have perfect kidney function. So a lot of times what I'll actually end up doing is rounding up their serum creatinine just to 1. So when I do my calculations, I have a little bit better assessment of probably what their actual creatinine clearance really is. Okay, that's kind of a little trick that I'll do to assess those patients. But also think about things that they have an amputation, they have really bad uncontrolled diabetes, they have like a leg amputation or something like that, that also is going to be affecting that serum creatinine. Should be seeing prolonged half-life of drugs because of that. So drugs are not being cleared as quickly from the kidney, so they're going to be sticking around for longer. Thus the half-life increases. So more risk for toxic concentrations, and again, also can be affected by the hydration status. So this is more common than you think. Patients come into the ER from the nursing home because they are very dehydrated. They're not clearing these drugs. They're experiencing toxicity now. So just an example, again, looking at the Cockcroft-Gault equation, notice that their serum creatinine is going to be falsely lowered, right? Because they're not producing as much muscle mass. That's going to do what to their creatinine clearance? So the serum creatinine is lower than it should be. It's going to falsely elevate the creatinine clearance. So it's going to overestimate what their function is, and so I can end up overdosing them on a drug over the long term. Okay, so this is why I need to make sure that we take this into account. That's why I'll end up rounding up for some of these patients. And there's other equations that you can use for elderly patients. This is just kind of a general all-purpose one for kind of adult patients. So just be aware you may see other equations being used there. So as renal function decreases, you should see serum creatinine go up, right? Because you're not able to clear it quite as well. But on the other side of it, if you're not producing as much creatinine, that could be falsely low, right? Or could falsely overestimate what the actual renal function is. So think about like, yeah, like an older patient who has lost a ton of muscle mass, right? They're not making as much serum creatinine, okay? I know their kidney function has probably still been diminishing over time, just like every old person does, but you're going to find that they're not really making as much creatinine as they should be based on what their actual renal function is. So when I plug in their serum creatinine into this equation here, the denominator is going to be lower than what it really should be, and thus it's going to falsely overestimate what their creatinine clearance is. Which is why oftentimes I just round up to 1 just to say like, okay, well at least they should be at least around this number, if not higher, and that way it gives me a little bit more conservative estimate of what the actual renal function is. Same thing if you had an amputation, a lot less muscle, it will have a falsely low serum creatinine, which will falsely overestimate your creatinine clearance. Okay. So we have this MDRD equation. This is more oftentimes used for older patients, especially with like renal disease. So it gets a little bit more complicated with some of the exponentials that we're using here. Also, sometimes we'll take into account if the patient is black or not, subject is female. So all these different factors will come into play with regard to what their serum creatinine should be. Okay. So, Looking at drug clearance from the liver, you should be seeing that the liver itself probably maintains pretty similar functional status, but a lot of it has to do with how much blood flow gets into the liver. So if they have any kind of like circulation issues, if they're having like CHF, or they're not really pumping enough blood around, and they have a lot of kind of fluid overload, that can impede the amount of liver blood flow you have, and thus less drug getting to the liver, less drug getting metabolized over time. So that can be one problem you run into. From the standpoint of first pass metabolism and bioavailability, typically you see some diminishment of the first phase 1 reactions. So you remember phase 1 reactions are going to be things that make the molecules more polar, or more water soluble, or get them ready for a phase 2 reaction. And CYP450 is the most important one out of that system, right? Really no changes to phase 2 reactions, but CYP can take a slight hit. But the biggest thing here is a decreased metabolism due to that impaired liver blood flow. It's much more clinically important than your CYP actual enzymes. Okay, so looking at some of the pharmacodynamic changes, so you may think like, oh, are geriatric patients just more sensitive than other patients? And so some of that could be related back to altered pharmacokinetics. So yeah, I give them the same dose of a drug as I would give a young person. They may not be clearing it as well, unless they have higher levels. Yeah, they would seem like they're more sensitive when really they just have a higher amount in the blood, right? So really pharmacodynamically, nothing has changed, it's all kinetics. But really what you can see in some cases as well is going to be they have kind of these lessened homeostatic responses. So for instance, a patient who is going from sitting to standing, they have much less ability to kind of have that compensatory increase in cardiac output to deal with that change in blood pressure, right? So that can be one of the things you can see there. But some other examples include things like temperature regulation. You may find that they are more cold or warm depending on the situation. They'll have issues with their fasting blood glucose, tends to ride higher as the patient gets older and older. It's kind of starting to wear out the pancreas and those beta cells. So all these things can change in making drugs more or less effective, right? So say for instance I'm treating a diabetic patient over time, and like I give them insulin, same dose over years, and it seems to be getting less and less effective. A lot of that is due to the changes in the dynamics, saying that, okay, well, the patient is losing their own insulin stores, or they are becoming more insulin resistant, whatever it happens to be. So you kind of have to look at it from both sides, both the kinetics and the dynamics. Okay. So let's look at some specific drug class examples and see how these can be affecting our geriatric patients. So sedative hypnotic agent. So this is kind of like the drug form of what I do to you guys most mornings, right? Okay. So anyway, looking at the half-lives of a lot of these drugs, many of them are metabolized within the liver. Some of them are going to be renally eliminated. You can see increases in their half-lives between 50 and 150%, right? So that means the drugs are sticking around for much, much longer, much more likely to have those kind of sedative type of effects. This means you're going to have also some drugs, when they get broken down by the liver, they actually have active metabolites, okay? This is similar to like prodrugs. You guys remember prodrugs where they're inactive and they get activated in the liver? Some drugs are active to begin with, and then when they get metabolized, you have active metabolites. So they can end up accumulating these, which are also going to be leading to more clinical effect, which can lead to these side effects. So these are really important for causing things like respiratory ataxia, falls, altered mental status. Think about things like your benzodiazepines like Xanax. Think about drugs like your barbiturates like phenobarbital. Those are good examples like sedative hypnotic agents. Looking at analgesics, we know we have a ton of people who are going to be on opioids. You find that as they get older, they're going to be more susceptible to these respiratory depressive effects. You're going to find that they also can accumulate active metabolites. And so for some of our older patients, there's a drug called propoxyphene. You guys ever heard of Darvon or Darvocet? It's an older analgesic. It was taken off the market probably when I was getting ready to get out of school, so probably like around the 2009-10 area. So that was actually taken off the market because what they found was these patients who were on this chronically, they would metabolize the Darvocet into a toxic metabolite that they could not clear very well in the kidneys, and they'll build up and cause seizures. They saw that enough of these patients were having these negative effects. They said, okay, well, it's too dangerous. Let's just take it off the market. Also wasn't super effective in the first place. But so that can be an issue there where they have active metabolites that are building up. They get more of those respiratory depressive effects, and then they can die. On the flip side, though, you have to think about some of these patients and the tolerance that they can develop to some of these medications. So, for instance, they'll have little old grandmas, like that 90-year-old, 40-kilogram grandma, who can be on mega doses of opioids. She can be on doses that would kill a horse. And why do you think that would be the case? So that tolerance we talked about, right? So over time, you're going to find that people get tolerant to those opioid effects, kind of like downregulation. They can have these kind of compensatory effects that make it so that 10 milligrams of morphine may be really good for them initially, but by the time they've been treated for years and years and years, they may need 50 milligrams or 60 milligrams. And so you guys ever heard like pill parties? Hopefully no one's participated in any of these. It's where like high schoolers are going and like raid their grandma's drug cabinet and then take it over to a friend's house, and they all just grab a random pill out of a bowl. Again, these are not very smart kids that are doing this. But if they take grandma's morphine or her methadone and she's on a mega dose, and then all of a sudden you're opioid naive and you take it, people have died from that, right? So you have to be very careful, because some of these patients will be on higher doses than normal because of the fact they have these tolerant effects and they've been working up to that dose over a long period of time. Okay. Looking at antipsychotics and certain antidepressants, so lithium is a really good example. Lithium is used to treat bipolar disorder in a lot of cases, but is entirely eliminated through the kidneys. Lithium looks a lot like sodium in the kidneys, and so if you're holding on to sodium, you're holding on to lithium too. So this can be a big deal. Patients will get dehydrated. They'll be in a state where they're actually holding on to more sodium, which can lead them to have decreased renal function, lead them to have high lithium levels. They end up seizing, they die, right? So we don't like that. If you put them on diuretics along with lithium, can sometimes raise their levels as well. Because again, if you're losing a lot of fluid, your body wants to hold on to salt to try to hold on to that water. So that can all lead to higher lithium levels. So we see a lot of side effects related to that. And then antidepressants, a lot of the newer agents are actually much safer nowadays. So if you ever hear the selective serotonin reuptake inhibitors or SSRIs, these are much safer drugs to use nowadays for elderly patients than our old school drugs. So fortunately, some things are actually getting safer for these patients. But we'll talk about those when we get to the psych section in Pharm and some moons away. And then I mentioned cardiovascular agents with antihypertensive, increased risk for that orthostatic hypotension. They go from sitting to standing, less blood flow to the head, they fall, right, and have a fracture or whatever it happens to be. They can also have a lot of electrolyte imbalances with diuretics. This can be really problematic, especially from the standpoint of potassium. They end up losing a lot of potassium. That can affect their heart function, can lead to having arrhythmias, right? So we don't want that to occur. And especially if they're on antiarrhythmics as well, mainly because if they end up developing arrhythmia, they have really poor hemodynamic reserves, so they're more likely to have a syncopal episode or pass out secondary to this. So just be aware, certain ones can have increased half-lives, so things like quinidine or procainamide. We'll go over those in the cardiovascular section in a few months, but all these can have extended half-lives, which means they can hold on to more of it, more likely to see an arrhythmia. Because one of the things you'll learn with antiarrhythmics is that even though they treat arrhythmias, they also can all cause arrhythmias as well. Okay? So we know with the adverse drug reactions that the more drugs are on, the more likely are to have adverse drug reactions. And say, for instance, you have a 10% risk for an ADR with just a single medication. By the time you're on 10 medications, it's roughly 100%. Like they're going to be experiencing some sort of side effect. Some of the times they may notice it, sometimes they may not. Sometimes it may lead them to be non-compliant with their regimen, mainly because they just can't tolerate the side effects there. But always take into account the OTC, the herbal medications they may be on. You always have to ask these questions. Good example of this. Are you guys familiar with like Goodies powders or BC powders? You know what's in that drug? It's aspirin, yeah. So a lot of the older patients, basically it's powdered aspirin, and it comes in this little kind of wax paper sachet, and they will dip it into their water, and they will just go ahead and drink it, right? So it's readily absorbed pretty quickly, and so a lot of patients will end up taking this for headaches. But a lot of them don't actually consider it medications, right? So they will go ahead and they'll take it for their headache, and they also take a baby aspirin for their their heart problems. It's very easy for them to get to overdose on this. So all patients are like, yeah, well, I took one BC powder for my headache, and then it didn't go away, so I took another BC powder, and I took another BC powder. It's very easy for them to get aspirin overdose, and it's because they didn't really consider it a medication, right? So I think it's kind of a southern thing. A lot of people from the north have never heard of these drugs before, but they're somewhat prevalent down here. So always ask about those type of products. Okay, you can also have prescriber errors, so make sure that you take into account their organ function over time. If their liver function is taking a hit, if their renal function is taking a hit, you have to assess for that over time. You can't just start them on a drug and leave them on it for the rest of their lives. You always have to go back and reassess your work. Patient compliance errors can be an issue, especially if they are having any degree of like kind of mental faculties are declining. If they're not really able to understand the instructions very well. Take for instance, if I said, take one pill twice a day. What do you guys think what that would mean? Take one in the morning, one at night, right? It's pretty easy for you guys. Well, okay, well, I'm only supposed to take one pill a day. I'm supposed to take it in the morning and night. I'll just split it in half. So now all of a sudden they're taking half the dose that they should be, right? So you can see where you need to make sure they actually understand what you're saying to them to make sure that the signals are going appropriately, right? So that's why we do a lot of patient education. We do that kind of teach back method where I say, okay, you're going to take it this way, so tell me how you're going to take it. And say, okay, we'll take one in the morning, one at night. Okay, you're good to go. All right, and you can kind of correct those errors beforehand. So that's really important there. And then just seeing multiple providers, a lot of different medications all get added on. And again, when you are going to when they go for the one provider, a lot of times they don't share systems, so they can't see what else other people have been prescribing to them. It's very rare that's the case. We have problems from the pharmacy standpoint because we can do a lot of that medication profile review, but if they go and fill at different pharmacies, they're like, well, I can get this one cheaper at Walgreens, but I can go to CVS and get this one cheaper there. Then now we can't see those profiles, and we can miss drug interactions pretty easily as well. Okay. So just be aware of that. All right, so again, when you're asking about a patient's medication history, it's important to make sure you're kind of assessing all features of it. So this is an example list of questions you can ask in order to make sure they're assessing all their medications. So one, are you using this drug as prescribed? So make sure they can tell you the dose that they're taking, the frequency, the form that they're taking, to make sure they understand what they're supposed to be doing. Ask about side effects. If they're deviating from not taking it, ask why that is. If they say, well, I get really dizzy every time I take it, so only take it at night before I go to sleep instead of in the morning. Okay, well, that's something to know. Like, it's something to say, well, maybe this drug's not good for you, or maybe we should adjust the dose in order to help prevent that. Ask about any medications. If they provide you a list, see if there's anything that they did not list on that they may be taking. Ask about non-prescription drugs or things they can get without. When you say over-the-counter drugs, they may not understand that. So say, are there any drugs you take without a prescription? Okay, that can be kind of an indicator to them, like, okay, that's ibuprofen I take at home, or the acetaminophen, because that can all play a role in their prescription meds as well. Ask about any homeopathic drugs, herbal medications, or vitamins. Again, you don't necessarily want to shun them from taking any of these, but you at least need to be aware of it. Sometimes people are like, well, I don't want to tell them about this herbal that I'm taking because my girlfriend told me to take it, and whatever happens to be. They need to be honest with you, and you don't want to be judgmental about that. Just be curious and say, what else are you taking? Because that can be very important. We had one patient who came in to the ER with a massive head bleed, and it was because she was taking warfarin. She was on that for her atrial fibrillation to prevent stroke, and then she ended up taking ginkgo because she wanted to help with her memory. And you'll learn that with herbal medications that any of the G ones tend to have antiplatelet effects or anticoagulant effects. So because she never told anyone she was on ginkgo plus this warfarin, ended up having a massive head bleed and died. Right, so these herbals can be very potent. Even though you may not think that there's a whole lot of merit to their use, but the patients you need to have that communication there. Right. So ask about drugs that belong to family members or any friends, right? So again, they sometimes will share medications. They say, oh, hey, I had a UTI last month. You can have the rest of my Cipro. That way you don't have to go and see the doc, right? Those can be problematic, especially if they have any interactions they're not aware of. It's about using drugs on demand or like illegal drugs from outside of the U.S. if they're ordering stuff from Canada or if they're getting things from disreputable sources, anything like that. Not to say that drugs from Canada are disreputable. It's probably a good thing if they're getting that cheaper. But any drugs that may be coming from sources that are not so reputable, that would be a thing to make note of. This is another big one. Ask if there are any drugs that are no longer prescribed. A lot of times that communication to say, hey, stop taking this med, never gets communicated to them, or they miss that point. And so which they take medications forever, even though they have been told not to take it anymore. That can be one thing you may need to assess for. And then when's the last time you checked your expiration date? Right? A lot of times they'll have medications from the 70s that are still taking or still have available just in case. Because again, who wants to throw away good medications, right? Most of the expiration dates on bottles are pretty bogus for the most part, but there's some things that actually do degrade appreciably, and so they should make sure they're not taking them outside of those dates. Because when you get a prescription bottle, you know the expiration date they put on there? Yeah, always put a year. Drugs are oftentimes much better for longer than that, but it's good to assess to see, like, okay, well, if it's from the 70s, maybe that's a little too far out versus if it was, from 2 months ago. So you at least make that assessment. There's a cool study where I guess a guy was working in his uncle's pharmacy, and he found all these old medications from the 1800s or something, and so he went ahead and tested their efficacy, tested the concentrations to see which ones are still there, and found that most of them were within 90% of what their actual stated concentration was. I think aspirin was one of the ones that actually got degraded very quickly, and I think phenobarb or something else, but most of the drugs actually were still good for a very, very long time. So yeah, expiration date is kind of bogus, but you didn't hear that from me. Say that last part again. Yeah. So say for instance, like someone comes in like, hey, just refill all my meds. The pharmacy, we may not know that someone's told you to stop taking that medication unless we hear it from the patient, right? Or unless you guys called us up, which is a rare instance. You guys are too busy to do that in a lot of cases. So we don't get that notification. We say, okay, we're going to fill all their meds. The patient gets 6 bottles. They're going to take all 6 meds. So yeah, that can be a comment, or it can be a reason for errors to occur there, for sure. Yep. This is why it's a big problem when, from the hospital standpoint, this is why medication reconciliation is so important when going from admission to, say, surgery, and then back to, say, the floors, because you need to assess all those medications every single time to make sure that the medications are on and still appropriate, right? So, for instance, we'll have a patient coming in for, say coming in for a seizure, right? So we'll have these seizure kids. They have a whole list of home meds. The doc goes ahead and reorders all of them. But maybe that's not the case. Maybe they should not be on one of those medications any longer. But if they don't actually go through and assess that, or if the nurse had put in the information incorrectly, that's where they can run into problems as well. So we actually had a pretty close call where the nurse went ahead and put in, the patient said they were on clonidine, which is a cardiovascular med. If you get too much clonidine, you get hypotensive, bradycardic, it's not good. So basically the nurse was going through and they said, okay, you're on clonidine, typed in clonidine, picked the first thing that came up, and it was a concentration that was wildly different than what we actually had in the hospital. So when the patient got admitted, the doc goes ahead and reorders that. And then fortunately, someone actually caught it to be like, well, this is a weird concentration. So we actually went back through and said like, okay, well, the dose that you would have prescribed was like a 10-fold overdose versus what actually the patient really does take, based on their actual home concentration and things like that. So you have to do your history. You have to make sure that you're actually assessing for things like what concentration are they taking, what drugs are they really still taking or should be taking. So all questions to ask. And then are they taking any medications independently? So again, if not, like who's helping them to make sure that, if they need a caregiver or someone to kind of help out with that, that can be very useful. They're using any kind of dosage system. So this is kind of like reminder systems, like, if you've ever seen like the pill boxes where they can put, Monday, Tuesday, Wednesday, like morning, noon, and night. Those can be very useful reminders for them to actually make sure they're taking it like they're supposed to. We hate those in the poison center world because they're so easy for kids to get into, and they're like, okay, well, he ate all of Monday's meds. All right, so let's go through and figure out which one of those are going to kill the kid. Most times it's not going to, but it's one of those things where you have to be like, okay, well, what's really the dangerous ones here, and try to go through that. But that's why any experiencing problems taking medications, they can't swallow well, if they're having any issues like that. That's why inhalational therapy is a big one. Any RTs in the room? I usually have like at least one RT, but ask about their technique, right? Because a lot of times if you were to have rheumatoid arthritis or osteoarthritis, it can be very difficult for them to use things like a meter dose inhaler where they have to squeeze and then coordinate their breath in to make sure they actually inhale the medication. If they can't do that, you may need to help them with some sort of assistive device or maybe use some other dosage form to get that med to them. So that can be a big problem over time as well. That's one thing is that eye drops, any difficulties actually making sure the drops are, make sure they're coordinated enough to actually get the drops in. If they forget to take medications, what do? Do they try to double up on the dose? That may be appropriate or may not be. Or if they, remember they stopped taking it for 3 days, they forgot, or they go on vacation for the weekend, come back, and they're, oh, I forgot to take my meds. Let me go ahead and take 5 days worth. Like, assess for that. See what their thought process is and make sure they can avoid them accidentally overdosing themselves. Okay. And then just any other comments or questions they may have about their meds is always good to follow up with. Okay, some examples of some pill minders. There's lots of other things out there. There's lots of applications that can kind of help you with this. There's dosage reminders. They'll actually call your phone and say, hey, take your med at this time. It'd be very useful to helping keep everything kind of straight, especially when you have a very complicated regimen. Taking things multiple times a day can all be very useful there. Okay, so just some practical application for some of these concepts real quick before we break. There's lots of obstacles to compliance, which we've already talked about. For instance, looking at medication expense. So say you have a patient with arthritis, you say, hey man, this new NSAID came out, the drug rep came by and said this stuff is like better than sliced bread. But the drug costs like $100 or more per month, right? That may not be feasible for that patient. So even though it's a great drug, it may be super safe and super effective, something like aspirin may be better for that patient, or something like ibuprofen. Right? Then go to Costco and get like a gigantic, like 1,000 pill count bottle of ibuprofen for like 99 cents practically. That may be way better for that patient. So always think about what can they actually afford, what's going to be best for them in the long run. Watch out for medications with mixed dosing intervals. If you can make everything one time daily and they can take it all at once, that's going to be easiest for compliance. And then always remember about this intelligent non-compliance. So this is kind of like where the patient will say, yeah, of course I'm taking it this way, but they're really not. Like they're saying, well, I don't want to tell them that I can't afford the full amounts. I'm only taking one every other day, or whatever happens to be. So sometimes they'll be a little bit more, crafty about that and trying to lie to you. And then just, again, assess can the patient physically take the drug. We run into this more in the peds side, where they can actually swallow pills or not. But stroke patients, patients with disabilities, they may not be able to actually use some of these medications depending on their physical capabilities. Inhalers is another big one there as well. Okay, so I'm going to wrap there. Any questions on the geriatrics? I like talking about peds more. It's more my jam. So that'll be fun for next week. So we'll do the review for physio tomorrow, and then the test will be on Friday, and we'll go from there. All right, I'll see you guys next time.